My name is Usman Said. I'm a consultant ophthalmologist at the Royal Liverpool University Hospital, and I've been doing cataract surgery for more than 23 years. Today we're going to talk about planning difficult cataract surgery and how to approach cataract surgery which is expected to be difficult. The important considerations are preoperative assessment in the clinic, surgical planning, communication, surgical gear, OVD, viscoelastics and Mollugan ring, phaco settings during fluidics, recognition of complications and the management. To consider what type of cataract surgery you're going to perform, whether this is a phacoemulsification surgery or whether it's small incision cataract surgery. In the Western world, cataract surgery is mainly undertaken with a phacoemulsification machine which breaks down the cataract and with a small incision, cataract can be successfully removed and a small plastic intraocular lens is implanted in the eye. When thinking about cataracts, especially hard cataracts, you've got to consider whether this is a brunescent cataract or white cataract or a relatively soft cataract. These are important considerations when planning and listing for cataract surgery. You've also got to consider comorbidity, for example, glaucoma, diabetes, corneal endothelium, astigmatism status, or any macular degeneration. You've got to try and identify any risk factors like pseudoexfoliation, small pupil, previous eye surgery, previous vitrectomy, and status of the other eye. For example, if the other eye is phakic or pseudophakic, and if there were any complications in the surgery of the first eye. This list is not exhaustive, and other factors might be in play that you might need to identify before planning cataract surgery. Once you've got to the stage where you've identified all these risk factors, you need to inform the patient about the prognosis, including what the patient can expect after cataract surgery, what the risk factors are, and if there are any expected problems or complications. When considering planning, you've got to consider what comorbidities the patient has. For example, if the patient has cataract and glaucoma, you may want to consider putting in an eye stent, a hydrus, or considering even more surgery like phacoemulsification with a trab or phacoemulsification with a tube, depending on what circumstances the patient has, what the intraocular pressure is, and what if there are any other factors that you may need to take into consideration. If a patient is diabetic and the patient has diabetic maculopathy, you may want to consider an anti-VEGF agent like Avastin, Lucentis, Eylea, or Vabysmo at the end of cataract surgery to reduce the diabetic maculopathy and the diabetic macular edema. If you may also want to consider a steroid implant like Ozurdex if you feel that the patient would benefit from it. Corneal endothelium is another consideration. Some patients will probably need viscodispersive like Viscoat only, but if the eye and the cornea is completely decompensated, it might be necessary for cataract surgery to be undertaken along with a corneal endothelial graft, and that would probably mean involvement of a cataract surgeon as well as a corneal surgeon. In patients who have a white cataract, vision blue is necessary to try and visualize the anterior capsule, and with the small pupil, Midrain or Mollugan ring are my first to go things. Communication is obviously very important. First of all, communication to the patient that the expected surgery is likely to be a difficult one and problems may or may not be encountered during or after cataract surgery should be communicated to the patient. The next is communication to the theatre staff. Before operating, you should inform your operating staff and your scrub nurse that this cataract is likely to be difficult. it may take more time than usual, more equipment might be required, and if the equipment is required, you may want to tell them in advance or tell the steps of the surgery in advance to your operating nurse. The gear that you might want is Helon or any other viscoelastic of your choice. Helon GV in case of a small or a shallow anterior chamber, or a Helon 5 in case of corneal Gattati or corneal endothelial failure. You might want to use a viscodispersive like Viscoat. Vision blue obviously will be required if you don't have a good red reflex, and mid-drain might be utilized to give intracameral in mid-drain to dilate the pupil. Maleugon ring is essential if intracameral mid-drain fails to dilate the pupil to the required dilation state. Most surgeons will have their phaco settings personalized on the phacoemulsification machine. The phacoemulsification machine in modern era has multiple modes which can save the phacoemulsification and fluidic settings of different surgeons. Make sure that you have your fluidics settings saved before you undertake difficult cataract surgery. You may need to work on a fluidics with easier cases before finalizing your own settings. And once you've done your own settings, use your own settings before undertaking cataract surgery. Recognize complications early. If you run into trouble, stop and think, revise a surgical plan, and then think about safety first. You do need to manage the complications, whatever that might be, whether it is zonular dehiscence, vitreous loss, posterior capsule rupture, or any other complications that might happen during cataract surgery.